Chapter 5 is the cardiovascular system, and the primary component of the cardiovascular system that we're the most interested in is the heart. So here we have a heart, and perhaps one of the first things you might notice is how many large vessels are coming into and out of the heart. So here we have coming in the inferior vena cava from the bottom. So that's going to bring in blood to the heart that's come from the body that is below the heart. The superior vena cava up here at the top is going to bring blood in from above the heart, and it all dumps in here to the right atrium. We'll look inside the heart here in a moment and determine the path of blood through it, but this is the incoming blood flow for the heart. If we look at outgoing blood flow, here we have blood coming up the pulmonary trunk to the pulmonary arteries here, and that's going from the heart out to the lungs. Then coming back in, we have pulmonary veins coming from the lungs back to the heart. And then up here, this really big vessel is the aorta. So that's going to take all of the blood from the heart that is oxygen rich and then distribute it to the rest of the body. So a lot of different major plumbing conduits going on here. If we look at cardiac muscle, the defining characteristic of cardiac muscle is going to be the presence of intercalated discs. And so in this image here, what we have is this little structure right here. We see it kind of scattering down the way here. And that is where we're going to find these gap junctions that we've talked about in a previous discussion in terms of communication, connections or junctions between cells. So this helps to make sure that heart muscle contracts in a very coordinated fashion. We want to make sure that cell 1 contracts, then cell 2 contracts, then 3, then 4, then 5. We don't want to jump from 1 to 4, then back to 3, then to 5, now back to 2. That wouldn't be productive at all. So these gap junctions assure that when one cell does something, it then sends that message to do the same thing to the next cell, and it prevents the message from jumping around, but it forces it to move from one end of the series completely through to the other. And that helps to ensure uniform contraction of heart muscle. If we look inside the heart, this is where we get the idea of blood flow through the heart. So let's do that. So here, let's say we have our blood coming from the superior and from the inferior vena cava, and it's going to dump into the right atrium. And this is a relatively thin-walled structure. You can see here the musculature of this chamber of the heart is relatively thin. And the job of the right atrium is only to push the blood from the right atrium down here to the next chamber, the right ventricle. That then means that you don't need to be muscular. It takes a little bit of muscle to push the blood just a little distance. You'll notice here the blood flowing through the tricuspid valve to get from the right atrium to the right ventricle. So this actually set of 3 flaps right here ensures that when blood passes through, the door opens, and then when the right ventricle starts to contract, the blood might want to go back into the right atrium. And these valves will then slam shut. So essentially, heart valves are one-way doors that ensures that things can go forwards, but they can't go backwards. You'll notice here the tricuspid valve and its sister valve on the other side of the heart, the bicuspid valve, or mitral valve as it's called in some cases, are attached to the bottom of the ventricle with these little structures called chordae tendineae. And that is to ensure that the valves do not open backwards. The pressure can be pretty significant on those valves, and without those anchoring chordae tendineae present, the valves might actually pop open backwards, and then that would allow reverse flow of blood. Again, that's completely counterproductive. So those chordae tendineae are actually very, very sturdy, and it's almost impossible for them to tear and allow that valve to pop open backwards. Now, I've done a number of dissections on hearts over the years, and never have I found chordae tendineae that very easily and readily tore or were compromised that would possibly allow those valves to flap backwards. When the right ventricle contracts, we can see here that the musculature of its walls are a little bit thicker, or quite a bit thicker actually, than what we saw in the right atrium, and that suggests that it needs to pump the blood farther. So here we can see that we've got some thicker musculature there, and it's going to pump the blood up here into the pulmonary trunk. So that's going to head out to the pulmonary arteries, going out to the lungs, and it's going to go through a valve here as well. So every time we go from one part of the heart to the next, it's through a valve. In this case, it's called the pulmonary valve. And that ensures that once blood goes up here into the pulmonary trunk and then pulmonary arteries, it cannot run back down into the right ventricle when the right ventricle relaxes to reset. So that blood then goes out to the lungs on each side here and would drop off carbon dioxide, pick up oxygen. And at that point, oxygen levels in the blood were quite low. So often when we think about arteries and veins, many people will define an artery as a vessel carrying high oxygen blood, and a vein is a vessel that carries low oxygen blood. And that's correct most of the time, but not always. So we can say for sure that arteries always carry blood away from the heart, veins always bring blood back towards the heart. So in this case, the pulmonary arteries are the exception to that idea of arteries equals high blood levels of oxygen, because the pulmonary arteries actually have the lowest concentration of oxygen of any vessel in the body, because every bit of it has been made available to the rest of the body at that point. The pulmonary veins coming back in from the lungs are the exceptions to the rule on veins always having low oxygen blood, because they are the highest level of oxygen concentration in the blood that you're going to see anywhere in the body at that point. The pulmonary veins lead back here to the left atrium, and you're perhaps thinking to yourself maybe at this point, we've talked about the right atrium and the right ventricle, but that was on the left side. And now we're talking about the left atrium, and we're about to talk about the left ventricle, but that's on the right side. And so that's a peculiarity of anatomy called anatomical position. And what anatomical position means is that the right is always the patient's right. The left is always the patient's left. So it's always from the perspective of the person whose part is being considered, which means if you're looking at it, it's going to be opposite. So what's on your left is that person's right. What's on your right is on that person's left. So if you put yourself on the operating table, now rights and lefts will always line up for you. So the blood came back in from the pulmonary veins into the left atrium, and the job of the left atrium is to push the blood to the left ventricle. Just like we saw with the right atrium, that's a pretty short trip, just an inch or so. So the musculature required for that is pretty minimal. So you see there the very thin layer of muscle. It goes from the left atrium to the left ventricle through the bicuspid valve that we already mentioned. And we should back up and say that these names, tricuspid and bicuspid, are actually descriptive. And I prefer them to mitral valve or to atrioventricular valve or any other way we could try to name these, because they are so descriptive. And that is that tri means 3, bi means 2. Cusp in this case refers to lips or flaps. So the tricuspid valve has 3 flaps. The bicuspid valve has 2 flaps. So that's very simple, very self-descriptive. So I personally like to think of them that way. If we look at the musculature here of the left ventricle, it is by far the most muscular of any of the chambers of the heart we've seen so far. And that's for good reason. The job of the left ventricle is to push blood from the left ventricle up through the aorta, out to the body, let's say all the way out to the fingers and toes, then all the way back up to the inferior and superior vena cava again to dump into the left atrium and start, or rather the right atrium, and start over again. So it needs to be thicker and stronger because it has to push harder to get the blood all the way out and all the way back. If you were looking at a real heart, it would be even more dramatic in terms of difference in musculature than you can imagine in this picture. So there's a huge difference, never any question about what side of the heart you're on when you're looking at those layers of muscle. And you can't see it in this image, but the blood is going to pass from the left ventricle up into the aorta. So the aorta is the largest artery of the body, and it's sort of a distributing artery. From the aorta, it starts to branch off blood to go everywhere. And you can see at the top here, the brachiocephalic and the left subclavian and left common carotid arteries there. Those are going off very quickly to the neck and head. So in a way, the head gets one of the first opportunities to get good fresh blood from the lungs. And as it goes into the aorta from the left ventricle, there's going to be another valve there, and that's going to be called the aortic valve. And again, is to make sure that blood doesn't come back down into the left ventricle in this case, when that ventricle relaxes and gets ready for the next contraction. So this entire process is happening very rapidly, 24 hours a day, 7 days a week. Some part of the heart is doing some kind of contracting or relaxing. If we look at this image, what we can get from it is this idea of lubs and dubs. And so we can see down here they're talking about a lub, up here they're talking about a dub, and this is really what's making the heart sounds. So if you've ever listened to someone's heart with a stethoscope, you hear this thump thump, thump thump, or if you prefer to think of it as lub dub, lub dub. And what's happening there is the sounds are being created by valves slamming shut. So the lub part, the first sound, comes from the atrioventricular, from the tricuspid and bicuspid valves slamming shut. The second sound, the dub, comes from the semilunar valves, so the pulmonary valve and the aortic valve slamming shut. And so that tells you basically the heart is completing one half of its contraction or completing the other half of its contraction with those two sounds. So a single heartbeat actually consists of those two independent sounds from two independent sets of valves slamming shut. The heart is an electrical pump, and it's a very sophisticated electrical pump. So here's a brief overview of the idea of the electrical system here. We have the SA node that comes up here in the right atrium, and that's the starting point of all heart contractions. So electrical current comes in from the nervous system, and it passes through the right atrium. It also immediately goes over here to the left atrium. So the atria are the first parts of the heart to contract. So right atrium is technically a split second ahead of the left atrium in contraction, but because they get the message first, they contract first. There's a little bit of a delay, around a 10th to a 20th of a second perhaps delay in getting the signal from the SA node where it came in to the AV node. And the AV node is what picks up that signal and sends it down to the ventricles. So the SA node brought the signal to the atria, the AV node picks it up from the atria, takes it to the ventricles, and that very brief 0.1 to 0.2 second delay ensures that the atria are not contracting at exactly the same time that the ventricles are. If they were both contracting, which one would win? This very thin muscular atria or this much thicker ventricle if they're both trying to push blood in essence through this door? So the atria contract, pushing the blood into the ventricles. Then the ventricles contract, closing these doors and pushing the blood on forwards in the system. So we got the atria to contract, the AV node picks up that electrical current and brings it down here, the septum, or this layer muscle between the two ventricles. And that muscle starts to contract. So as you would imagine, whatever part of the muscle gets the signal first starts to contract first, so the ventricles start to contract here in the middle, and then that signal goes and wraps around the outside of the ventricle. So in a way, ventricles contracting are sort of like you making a fist. If you look at your hand as you make a fist, really what starts to happen is the palm starts to close up first, and then the fingers wrap around and complete that fist. So what's happening in the heart is think of that septum in the middle as the palm. It starts to contract, then the rest of the ventricle muscles wrap around that, closing them off in a somewhat circular fashion, just like making a fist. So atria contract, then ventricles contract. And while the ventricles are contracting, the atria are relaxing, in this case refilling with blood. While the atria are contracting, the ventricles are relaxing, refilling with blood. So if one's contracting, the other one's relaxing, refilling with blood, and ready to start the whole process over again. We can actually monitor that electrical current and get an idea for how effectively the heart is doing this pumping thing. So in the top left here, this normal EKG, and in the United States we often call it EKG. even though our spelling would be ECG, electrocardiogram, but the British spelling is EKG, and that's just sort of the designation that we often have in our head. So really what that's doing is it's measuring the electrical current while the atria and ventricles are contracting and relaxing. What you see is a P wave, then a QRS complex, and then a T wave at the end of this process. So what's happening in the P wave is that the atria are starting to contract. So they've received their electrical current, they're starting to contract. By the time you get to the QRS complex, the atria have pretty much wrapped up their contraction, and the QRS complex starts ventricular contraction. By the time you get to T, the ventricles have contracted, they're done with contraction, and the T wave is when the ventricles relax and reset the current. So there's a spike in current for the atria to contract, a big spike in current for the ventricles to contract, and a small spike in current for the ventricles to relax, resetting the system and be ready to start all over again. So that very normal pattern that down here in our bottom image we can see over and over, this same pattern. So it's a little bit small, but here's a P, QRS, T, P, QRS, T, P, QRS, T, over and over again. Very rhythmic, very well patterned. So that's a normal, relatively happily functioning heart when you get that sort of function. If you get something that looks like image B here, we don't have defined P's and T's, and our QRS's are not very clean either. It's sort of just spasming. And this technically means, this ventricular fibrillation literally means the ventricle is just twitching, it's quivering. And so you're not getting any kind of good uniform contractions of heart muscle. It's just sort of spazzing out. That's the sort of thing that a defibrillator can try to help with. And what a defibrillator does is it tries to defibrillate, so to cancel out the fibrillation or the quivering. And what it tries to do is send a massive volt of electricity in there to sort of wipe out all of that current that's there and let it start from scratch. So it's just giving the heart a forced reboot, get that spasming electrical current wiped out, and then allow the system to start over. And often that will do the trick. If that doesn't work, then there's a few other things that can be tried to level out the heart. But typically, if it's fixable, a defibrillator is going to do the trick for you. When we think about heart and heart function, we need to think about blood pressure. So what is a normal blood pressure? And perhaps more importantly is, what is your blood pressure? So if we look at this table here, and these numbers are always changing a little bit, but I'm relatively happy with these numbers, is that normal would be defined as the 120 over 80. Those are numbers that everybody knows about. And so we're going to say that really 120 over 80 is the top end of a normal good blood pressure. Then we get to the elevated blood pressure range, which would be 120 to 130, and still below 80 for your bottom number. And we'll define what those numbers mean here in a minute. Stage 1 hypertension would be 130 to 140 for your top, and 80 to 90 for the bottom. And then stage 2 hypertension would be 140 or higher over 90 or higher. And we might then say that this elevated range could also be classified as pre-hypertension. But either way you look at it, if your blood pressure averages over 120 over 80, that's something that you might want to take a look at and think about what's going on there. So what is it really that we're measuring when we talk about these numbers? And what we're really measuring is we're measuring the maximum pressure and the minimum pressure that occurs within any particular artery at any particular time. And for me personally, this particular graphic is very useful to understand what's happening. So the first step in taking someone's blood pressure is to apply the cuff. And the cuff is designed to, as you would know, squeeze the arm, and it feels like maybe it's going to squeeze the arm off, but it really won't do that. What it's actually doing is it's pinching off an artery there in the arm, right above the elbow, and you can see here it's closed that artery off. So there's no blood flow going through there. And then the person is going to slowly let the pressure off, and as that pressure comes down, and we should start here. You don't want to start the pressure at 300. That might actually cause some arm damage. Start it somewhere around the 160 mark is my personal preference. And then they're going to slowly let that pressure off, and as that pressure comes down, they're listening with the stethoscope. And the first time they hear heart sound, so they hear a heartbeat, return to that area for the first time, that's when that artery is just starting to open up again and allow some blood to go through. So that's the top number. That was the maximum pressure that that vessel was able to experience, or I guess another way to put it is that's the maximum pressure that the heart was capable of generating at that point of the body when it finally forced that vessel back open again. You continue to listen and the numbers will keep coming down, and then you keep listening until you no longer hear any heartbeat. That's when that vessel is completely open, it's got no restriction on it whatsoever, and heart beating or heart not beating, you don't hear it either way. So that's the minimum pressure that occurs. That's, we could say, the constant pressure in that artery that would occur no matter what's happening with heart function or not. So by measuring the maximum and minimum blood pressures, we're able to determine, is it high enough to actually move blood through? Is it low enough that it's not damaging that blood vessel as it's going through and putting excess pressure on the heart as well? So the 120/80 is the top end on highest pressure and lowest pressure that we would like to see. So we really say that a healthy blood pressure is going to range a little bit from one person to the next, but a truly cardio healthy person shouldn't have a blood pressure really running average over the 120/80. If a person is very physically fit, does a lot of exercise, a lot of working out and physical activity, that person's pressure might run a whole lot lower. So in terms of what would be a blood pressure that's too low is a little bit subjective. One person might have a blood pressure of 100/55, and if that was the case for me, then I would be in serious cardiovascular problems because my heart wouldn't know what to do with that kind of pressure. But as someone who's very physically fit, that might be something that is average for them. So on the top end, we can agree that 120/80 is really as high as you wanted to see it in a resting condition. And we should back up and say we're talking about resting blood pressures here. So when we're looking at these numbers, we're not talking about numbers right after you get off the treadmill. We're not talking about numbers right after you're walking around in the grocery store even. We're talking about numbers that occur after you have been sitting down and resting for at least 10 to 15 minutes. Now, how often do you go to the doctor and have a 10 to 15 minute resting period, sitting down, comfortably relaxed, before they take your blood pressure? The answer is probably not. So what you often find is blood pressures taken at the doctor's office are higher than they really average for you in real life because you're not truly taking a resting blood pressure. You're taking some degree of physical activity blood pressure. And the more physically active you are, the higher your blood pressure needs to be to support that activity. So if you're exercising and out moving around, blood pressures in the 130s or a little bit higher over the 80s to low 90s is not a big deal for someone who's actually active right now. But again, if you're resting right now and have those numbers, that's where the problem comes in. So at the doctor's office, you often get that high pressure because they didn't allow you to recover. And I don't know where along the lines they forgot these very basic concepts, but most every time I've ever had a quote-unquote healthcare professional take my blood pressure, they've almost always done it without any kind of resting and recovery period. So I guess we're saying that if your numbers are slightly elevated when you're at the doctor, probably not anything to worry about because you probably didn't get a resting number. On top of that, some of the ways they have you take it, by bending your arm, by holding your arm up in the air, those are horrible ways to get it because that's artificially changing blood flow through the arm as part of that positioning thing. So you should always have your arm out to the side resting comfortably on something because muscle tension in the arm can also mess with your blood pressure reading a little bit. probably an even bigger contributor to high blood pressure at a doctor's office is a well-known phenomenon called white coat syndrome. You're probably not at the doctor because you know for sure you're in perfect health. You're at the doctor, you might think you're in good health, but there's always that possibility of maybe not. So that adds a little bit of background stress to the situation. Almost never do you walk into the doctor's office and get called back to the room on or before your appointment time. So that adds some additional stress and pressure to the situation. And then you plop down and they immediately take the pressure in an inaccurate way. So all those things together give many people's blood pressure readings in a healthcare setting an artificially high readout. So if you get a reading of 130, let's say over 86 in a doctor's office, that's probably not a big deal. Probably if you were at home resting and everything was going okay, you'd probably have a number that was down there in that acceptable range. Another question that might come along is, what is it that determines blood pressure? And this is a very complicated formula, but the short answer to this is there are three things that are the primary contributors to blood pressure. One of those is vessel diameter. How big is the tubing? The bigger the tube, the lower the pressure can be to move that amount of blood through. The smaller the tube, the higher the pressure. And your body is actually able to adjust the diameter of arterioles. Those are little small arteries. They're able to adjust those very easily. And that helps to then very rapidly increase or decrease your blood pressure. And your body's constantly, 24 hours a day, 7 days a week, it's fine-tuning your blood pressure by dilating or constricting those little arteries to then change this vessel diameter. So that's perhaps the biggest piece of the puzzle, is vessel diameter. Another big piece of the puzzle here is heart rate. The faster the heart pumps, the higher the pressure goes. That sort of makes sense. The third big piece to this puzzle is vessel length. The more miles of blood vessel you have to push that blood through, the higher the pressure has to be to get it pushed through. So this is one of those things, you can't necessarily consciously control your heart rate. You can do some things to try to affect it, but you can't literally tell your heart, slow down, and actually get an immediate response. You can't tell your heart to speed up and immediately get a response. So the idea of biofeedback says that you can tell your body what to do and then it will respond. And that's just garbage. You can't tell your heart to do something and actually get an immediate response. So you can't really affect heart rate immediately. Obviously, you can engage in behavior patterns that require a lower heart rate and eventually get there, but immediately you can't do anything about that. Vessel diameter is 100% out of your control. You have no conscious control over how big or how small those arterioles constrict or dilate. So that was something that you really can't do a whole lot about either. But there's one thing that you can do about your blood pressure, and that is relative to length of blood vessel. If you're overweight, simply losing weight will lower your blood pressure. Because when that fat is eliminated from your body, the blood vessels that were supplying that fat with blood are then eliminated as well. So literally by losing only a few pounds, you can eliminate miles of blood vessels from your body. Obviously then you've reduced the distance blood has to travel significantly, and then your blood pressure would go down. So it's then no surprise that overweight people often have higher blood pressures than people who are of a healthy weight because they have more miles of blood vessels to push the blood through. So for me, if I would lose the weight that I need to lose, and if I could lose 43 pounds, that would get me down to weighing only 200 pounds. So right now I weigh about 243 pounds. If I eliminated that 43 pounds of fat, I could then eliminate the miles and miles and miles of blood vessels that were supporting that 43 pounds of fat, and then my blood pressure would go from the high 120s over 80 to the low 120s over 80, or probably even below that a little bit. So I would get a significant improvement in average blood pressure if I would simply lose a couple of pounds of fat. And most of us in the United States could stand to do that. So most of us would actually experience an increase in health in a number of different ways, but especially in blood pressure if we would lose weight. Now some people And you know who you are, and us fat people hate you for this, but skinny people can't really or don't need to do that, so that's not going to affect a thin person's blood pressure. But a person who is like myself and most of us, carrying more pounds of fat than we really need, could benefit in a blood pressure direction by losing some weight. If you have blood pressure that's too high, you're then looking at things like the possibility of blowing out blood vessels. If your blood pressure goes too low, then you might not have enough pressure to it to keep it moving forward. So there's that happy medium there. If you've ever noticed that when you stand up suddenly, you might feel a little bit lightheaded and dizzy for a few seconds, that's because while sitting down, your body adjusted to make the blood pressure it needed at that point. When you stand up suddenly, your blood pressure drops. And that sudden drop in blood pressure and therefore blood flow to the brain temporarily deprives the brain of oxygen, and you become a little bit dizzy. Within typically a couple of seconds, you clear up because your arterioles will constrict a little bit and increase the blood pressure, get more blood flowing back to the brain. And that typically happens pretty quickly, but if you've ever noticed that feeling dizzy for a little bit of time after standing up quickly, or after having been bent over and then you straighten up quickly, that's just a sudden drop in blood pressure that's typically straightened out pretty easily. The good news is the heart is not the only thing that's involved in moving blood. If that was the case, we would have real problems. Blood would get out to the feet without any challenge because, well, gravity pulls blood there for free. Your problem would be getting blood back up out of the feet to the rest of the body. Therefore, a couple of ideas need to happen. And one of those is in veins. You can see here these veins going back towards the heart have valves in them. And those valves are there, just like the valves in the heart were, to make sure that blood goes forwards and doesn't go backwards. Without those valves, every time the heart contracted, it would push the blood forwards a little bit, and then gravity would pull it right back down. And then basically the blood would just slosh back and forth in your feet and never get anywhere, causing all kinds of problems everywhere from swelling of the legs and feet simply to not having enough blood in the top half of the body. So those valves help to make sure that when the heart contracts, it pushes the blood forwards through a valve. As the heart relaxes, that valve closes, holding it in position, and then having it ready for the next heart contraction to push it up past the next valve. So it goes up, stops, up, stops, up, stops. And that's very useful. Occasionally some problems happen with those valves, especially in the legs, and it then gets labeled as varicose veins. And basically that's when a valve is popped open backwards, or perhaps many valves have popped open backwards, and that's allowing the blood to pool in those vessels and not keeping it moving forward a little bit at a time. High-risk behaviors for developing varicose veins is doing a lot of sitting, having a sedentary lifestyle, doing a lot of sitting with your legs bent, because every time your leg is bent, especially at the knee, that somewhat kinks off the blood vessels. And so a lot of people develop varicose veins first in the lower legs. Varicose veins run the gamut from mildly inconvenient to majorly inconvenient, and we would certainly agree that cosmetically they're not desirable, but actually physiologically, biologically, they can have some problems. Obviously, those vessels are getting stretched beyond what they're supposed to, and they can actually pop out under the skin to be kind of bulged, and they can often get very convoluted and twisted looking, and it can actually be very cosmetically unappealing in a severe case. So that's the cosmetic side. The blood vessel being overstretched is going to keep it from getting back together, because as that vessel is pulled open, the valves don't actually close on each other nicely. The problem here with these valves and veins is they don't have chordae tendineae to hold them in place, so they can pop open backwards. Another problem is because this blood is pooling, you get blood clots that form when there's no need for it, but simply because the blood is flowing so slowly, it's not staying mixed, it's not moving along. There can be significant pain with this because those blood vessels are overstretched, because the nerves associated with them are getting pressed on by the swelling. And you can get just overall swelling in the limbs as well. So really sort of an inconvenient sort of thing that can be an actual problem. The solution is a couple of things, and one might be a surgical approach, and they might actually go in and do a process called venous stripping. And what they'll do is stick a little wire in there that snags those valves and pops them back in place in a forward direction. The word on the street for the doctors who perform those procedures is that within about 2 days you're going to be back to normal activities, so it's a pretty quick recovery time. And hopefully that will do the trick, just getting them back in position again. But if you continue doing the same things that led to the development of that in the first place, then you're just going to end up right back in the same situation. So on top of getting it fixed that way, perhaps, you do need to become more physically active. And then you're going to get a secondary pumping mechanism here called a skeletal muscle pump. So what you see here, not only are the valves, but you see the muscles on each side of that blood vessel. And when you move, those muscles contract in picture A, which squeezes the vessel, pushing the blood towards the heart further. When the muscles relax, the vessel refills with blood, muscles contract, squeeze it on out. So it's sort of like mini pumping stations throughout the body when skeletal muscles contract and relax on blood vessels. And that's especially important again in the legs, where gravity is our biggest opponent to getting blood back through the system. If you've ever worked in, let's say, a factory setting, or any kind of setting where you're on a hard floor, perhaps just standing around for long periods of time, you discover that your legs swell, they hurt, and then if you, let's say, sit down and prop your feet up, it feels amazing. And what's happening then is gravity is helping to empty that blood that's accumulated out of the system. So you've got the valves in place, and they're working while you're standing there, let's say, at that assembly machine, but you don't have any skeletal muscle pump helping. So if you're walking, even if you're on the same hard floor but you're walking around a lot, you'll discover that that's not nearly as much of a problem because the skeletal muscle pumps are that helpful at keeping blood pushed along through the system. Here on the left we have an arteriole. That arteriole connects to what we call a capillary bed. So the red, purple, and blue network in the middle here is a capillary bed. And capillaries are actually where exchange occurs. So oxygen is dropped off and made available to body cells. Carbon dioxide is picked up and taken back to the lungs. Nutrients are dropped off. Waste products are picked up. And along the way, water also leaks out as well. So capillary beds are leaky, and because they're leaky, you then need the lymphatic system. Because capillaries cannot reclaim all of the fluid that come out. So let's say about 20 liters of fluid leaks out of capillaries every day. By the way, that's more fluid than you have in your entire body, so that would be a problem if it stayed there. About 17 of those can be reabsorbed by the capillaries. That leaves about 3 liters a day that didn't get reabsorbed by the capillaries. So the lymphatic system and the lymphatic ducts actually pick up that extra 3 liters of fluid a day, filter it, and then return it back to circulation again. After that blood goes through the capillary bed, it's picked up as much waste and as much of the water as it could. It then moves over here into venules on the other side. And venules are small veins, which then connect to larger veins and then eventually go back to the vena cava. So everywhere in your body has capillaries. There's no cell in the body that's more than a few micrometers away from a capillary bed. So that really means that all cells have a blood supply very close by. If we were to talk about shock, if someone is experiencing shock, what we could do is test for that by doing what's called a capillary refill test. So if you suspect someone might be in shock, what you can do is the easiest part of the body to get to is fingers to get a good for this. And what you would do is pinch the finger, and that's going to squeeze the blood out of those capillary beds. Then you let go of the finger and you count how many seconds it takes for the finger to pink back up. In essence, for those capillary beds to refill. And that's giving you an idea of, is there enough blood pressure to refill these capillaries quickly? And that really tells you then, is there enough blood flow to all of the cells of the body to keep things functioning? And one of the things that happens very commonly with shock, and it doesn't matter what kind it is, it's an inappropriate distribution and supply of blood. And so if the finger is short on blood, odds are the brain is too. And the finger is just something you can get to very easily. So a healthy capillary refill test, a cap refill time we would call it, would be somewhere in the neighborhood of 2 to 4 seconds. If it goes much past 5 seconds for the area to recolor to the color it was before you squeezed it, then that probably suggests that part of the body has decreased blood supply below the levels it would really like to have. One thing that happens with arteries perhaps, and especially with coronary arteries, is the buildup of a plaque or a blockage. So you know all about cholesterol and fat in your diet causing coronary artery blockage, and there's some truth to that, but some people are just more prone to problems than others. Some people could eat a high-fat, high-cholesterol diet their whole life and never develop these, and others would develop it for no cause at all. But the point here is you have a blockage. This buildup of fat then starts to reduce blood flow through this vessel. And remember that we said blood pressure was greatly dependent on vessel diameter. So this vessel now has lost, this particular one has lost around 50% of its diameter available for blood flow. It's a very complicated formula that measures blood pressure and changes relative to vessel diameter, but I can tell you that very simply, if there's a 50% reduction, or the 50% reduction in diameter of the blood vessel, so a 50% blockage, you're inclined to say, well, that's half. Yes, it's not good, but half, well, not a big deal. But a 50% reduction in blood vessel diameter results in a 16 times change in blood pressure and blood flow. So it's not that you just lost half the blood flow and maybe have twice the pressure. You've got 1/16 of the blood flow and 16 times the pressure at that location. So that's a really, really big deal with something that you thought 50% wasn't a big deal. 50% is a big deal. You can then imagine the significance of someone with an 80% blockage. Now we're talking a more than 16 times change here. And again, that's a very complicated formula that I don't begin to understand, but I trust the people who worked it out knew what they were doing. So that means if you have an 80% blockage, that's almost no blood flow going through and a huge blood pressure buildup at that spot for the blood trying to go through. And because these are arteries supplying the heart with blood, that means the heart is now experiencing blood supply and therefore oxygen supply shortage. The heart doesn't get oxygen from the blood going through the chambers, but rather you can see in the upper left here, the coronary arteries come out of the aorta. So as soon as the aorta leaves the left ventricle, the coronary arteries plug in and get the heart really the first chance at oxygen, and then the brain gets second chance. But if those arteries are blocked, wherever they're blocked, you have loss of blood flow past that. So let's say that you have a blockage of this little artery right here. So that means this section of heart out here at the tip is deprived of oxygen. And a heart attack then is when a chunk of heart tissue dies because of lack of blood supply, because of lack of oxygen. So that might cause a minor heart attack out here at the tip. If, however, that blockage occurred up here towards the source, everything from there on out, so this entire half the heart, would then become oxygen deprived, and that might cause a massive heart attack. In that case, the person most likely fell over dead because half the heart died. So you can have a small piece of heart muscle die and survive the experience, but if you have a large chunk die, that could become life-threatening. Another little oddity about this, and I can't begin to explain it fully, but it is just the case, is that the older you are when you have a heart attack, the less likely you are to die from it. When you see a 40 to 50-year-old male, especially, who has a heart attack, they almost always die. But all the time you hear of 70-year-old people having heart attacks, and yes, it was inconvenient, but it doesn't often kill them. And partially that can be explained by how long did it take to build up these blockages. If a person abused their body such that in 30 to 40 years, maybe 50 years, it built up this kind of blockage which caused that kind of damage, they were abusing their body more aggressively than someone who had 70 years of abuse to build up to the same level of impairment. So the younger it happens, in a way, the more hard a harsh treatment you've been giving your body, and it's just a little bit more fragile. There's probably something to be said, too, for older people's arteries being a little bit more flexible and handling blood pressure shifts a little bit more. Probably that has to do with muscle tone getting a little bit weak, because these arteries do have muscle in them, and if that muscle gets weak, then it kind of dilates a little bit and becomes a larger diameter, so it's not as likely to be an issue that way too. So the point here is, if you're going to have a heart attack, the further off in life you can put it, the more likely you'll be to survive it. Or better yet, just be healthy, have a reasonably low fat and cholesterol intake in your diet, and a good amount of exercise, and then you probably will never have this kind of issue. If you hear about someone having a regular heart bypass, we're talking about one artery was blocked and it's repaired, and we'll look at that in a minute. If you hear of someone having a double bypass, there's 2 blockages. A triple 3, a quadruple 4, and if there were more than 4 blockages, the person was probably dead, and it doesn't matter what we do after that. So the point is, the more of those blockages you hear about needing replaced or fixed, the more places within the heart that there was a restriction of blood flow. So here's an example of a cardiac bypass procedure. And basically what you're doing is you're going around the blockage, and you're trying to restore blood flow to the area beyond the blockage. And this particular example would be a triple heart bypass. And so there were 3 different places where it was significantly blocked and needed a problem fixed. So that's one way to do it. That is a very intensive, significant, and also quite risky surgery to have that level of slicing and dicing done on the system. A much less invasive procedure might be an angioplasty. And that's what you see at the bottom here. Basically, a wire is inserted, usually through the femoral artery in the leg, and then worked back up into the heart. And wherever the blockage happens to be, they can blow up a little balloon, which stretches that blockage open again more completely. And then they might actually put in a stent. And that's basically an insert that will hold that vessel in that stretched open position, again restoring blood flow. Angioplasty procedures typically are good for 5, maybe 10 years, but if you don't do some serious lifestyle changes in that time frame, it'll probably just clog up again. So it's a less curative for major problems, but for a minor blockage, that might do the trick. Something like a 50% blockage or beyond, we really can't fix that just by blowing it up with a balloon and putting in a little insert. So that would probably need more of the bypass procedure. We could go on about heart problems and heart function and heart things all day long, but this is a little overview of the heart system. So hopefully everything made sense, you learned a lot, and everything worked for you. Thanks for joining us. Have a good day, and we'll see you next time.